Welcome to the SCMA Foundation's Patient-Centered Medical Home webinar series. My name is Scott Holtstrand. I'm the project director of this project where the South Carolina Medical Association's foundation is assisting primary care practices with their transformation into patient-centered medical homes. I want to thank Claudia Cartledge for her assistance in preparing this webinar. This is the fifth in a series of webinars that has been explaining the NCQA standards for patient-centered medical home. And in the last several months, we've looked at Standard 1, 2, and 3, and today this seminar is about Standard 4. Standard 4 is all about care management and support of patients, particularly your high-risk patients with chronic conditions that are difficult to manage. Standard 4 typically is one of the hardest standards to achieve, both in proof to NCQA and in execution in your office. And the reason for this is there is a lot of clinical workflow that needs to either be changed or tweaked or otherwise converted in order to comply with NCQA standards for care management. And in many cases, practices are doing much of what NCQA requires, but does have to think carefully about how they are going to record what they're doing so that they can prove to NCQA that the care management they're offering is in line with NCQA standards. So today we're going to focus on Standard 4. And if you look at this next slide, you can see Standard 4A, Element A, is all about identifying a high-risk population that you are going to care manage. NCQA does not expect that you are going to care manage all of your patients. What they want you to do is use this information that you see on this slide to determine who your highest risk patients are, those patients that need the most care. And then once you've identified those patients, it is those patients for whom NCQA requires care management. If you look at number 6, factor 6 on this towards the middle of the page, one thing that NCQA requires is that you must report to them the number of patients, actually it's the percentage of patients of your patient population who enter into your high-risk care management plan. Although they don't give a strict or hard number for what you should be shooting for. Typically, we recommend around 5% of your patient population. So, for example, if you had 5,000 patients, NCQA would expect that you'd be care managing maybe around 250 of your patients, give or take. And there's a lot of reason for this. One of it is that typically your 5% most difficult patients are resulting in most of the needed care. For example, statistics nationally suggest that 5% of the patient population is contributing to 50% of healthcare costs. And then the other 95% of your patient population contributes to the other 50%. So there are a number of legitimate reasons why 5% is a good number to shoot for. If you have a much higher patient population, 5% might be too many to handle. And so we can work with you to identify what your high-risk population should be. And to assist with that determination, NCQA lists 5 categories. If you see those factors there, 1, 2, 3, 4, 5, starting with behavioral health conditions and ending with referrals by outside organizations. And what NCQA wants you to do is they want you to use these categories to define who your high-risk patients are. Just let me give you an example. Let's say behavioral health conditions. You have an adult population and you say, you know what, I want to look at depression. Depression is making my patients higher risk. And so what NCQA wants you to do is use your EMR to identify all patients with a diagnosis of depression. And then if that is who you want to be in your high-risk category, you can include them there. My guess is, in many cases, that's going to be a really big number. And so what you can do is you can make your thresholds higher. For example, instead of just saying depression, you might say, I'm going to select all my patients with depression and an anxiety, like an associated anxiety, anxiety disorder. Or on the high cost, high utilization, as an example, you might say, I want to look at all my patients who've been admitted to the hospital at least once in the last 6 months. And when you run that list, you find, wow, this is more than I expected. I don't think I can care manage all these patients. So you might make your threshold higher. You might say, you know what, I'm going to look at all patients who've been admitted to the hospital at least 3 times in the last 6 months. And that might give you a more manageable number to apply to care management to. And so what NCQA wants you to do is just go through each of these 5 categories and set your own thresholds. And of course, you've got to think through a couple things when you set those thresholds. One of them being, can we even identify patients in our EMR using that threshold? For example, social determinants of health. I've had some folks that thought it might be a good idea to identify certain patients who were on free lunch, free school lunch. These were pediatric office. But they just didn't have that category in their EMR, and they wouldn't be able to stratify their patients that way. So what some practices I've worked with have done is they've identified a zip code or zip codes that are in health disparity areas, and they make that social determinants of health. You can go a lot of different ways with that. And I guess the good news about this is that NCQA gives you a lot of flexibility. The bad news is that NCQA gives you a lot of flexibility. So it means that you've got a lot of opportunity to select patients that are meaningful to your office, but it also means that there's so much leeway that it can be sometimes hard to narrow it down. So what we have done is we've worked with practices to identify important conditions and more complex issues to be able to narrow down this high-risk patient group to a group that's more manageable. And so once you've used the categories that you've listed here, you then count up the number of unique patients. You can't include patients that are in 2 categories as 2 patients. For example, if you have let's say on poorly controlled or complex conditions, number 3 there, you select diabetics that have LDL levels above 100. And then for high cost, high utilization, you pick people that have been to the emergency department more than 3 times in the last year. And some of the diabetics with LDL above 100 have also been to the ED more than 3 times. They meet both thresholds. That's okay, but you can only count 1 patient 1 time when you're making your percentage calculation for factor 6. So I encourage you to talk with your clinical team and come up with a category. And here's where it's important to make it meaningful for your office. Pick patients that you think would truly benefit from some additional attention. This is a slide from NCQA that shows a little bit of how you can have overlap of your patients. For example, you could have a diabetic with LDLs above 100 who also has depression with accompanying anxiety, who's been to the hospital a number of times, who lives in a certain zip code. They'd be in 4 different categories, but they would only count as 1 patient. Did want to point out one more thing. Number 5, referrals by outside organizations. Oftentimes, if you're in a network or if you are contracted with certain Medicaid managed plans or with certain insurance companies, they will send you a list of their high-cost patients. And so what NCQA wants you to do is take patients that have been sent to you, whether it be from an insurance company or through a network that you belong to, like an accountable care organization, and use those lists to pick out high-risk patients as well. This is another slide from NCQA. And if you look here across the top, they've gone through and they've calculated how many patients, this practice, how many patients is in each category. And if you look, it totals 350, but in actual unique patients, it's just 275 because they had 75 patients that were in more than 1 category. And so that's how they got to 11%. And again, that's just a suggestion. You can do as much as you want, but I do encourage you to pick a population number that is manageable for you and actually makes clinical sense for you to be doing additional care management for. So the question now is, okay, we've identified the patients that we want to care manage. We've identified our high-risk population. Well, what do we do? What does the care management look like? And that is standard 4B and 4C. So what NCQA wants you to do is they want you to develop a care plan that you give in writing to the patient. And that care plan in writing has 4 components. One is you've got patient preferences and functional lifestyle goals. 2 is you've identified your own treatment goals for the patient. 3 is if you've assessed and addressed any barriers that might exist for the patient meeting those goals. And then the 4th is including a self-management plan of what you give to the patient. And all of this needs to be given to the patient in writing or to the patient's family or caregiver, depending upon the situation that is involved. And so just as an example, let's say you have a diabetic patient that is part of your high-risk population. So for number 1, you ask the patient, what are your goals for your care? And the patient might say, you know what, I want to be able to go out to dinner and not have to take insulin because I'm actually picking the right things to eat. Or the patient might say, you know what, I want to be able to walk 30 minutes a day, 4 days a week. Or I want to be able to attend my son's high school graduation, and there's going to be a lot of standing up, and I'm just not there yet. You know, whatever the patient goals are, you incorporate that into the plan. And then, of course, your own treatment goals will likely be more clinical in nature, but don't have to be. But an example would be, let's get your A1Cs below 7%. Let's get your LDLs below 100. We need to get your weight below this certain, or your BMI at a certain percentage, that kind of stuff. And then any barriers that might exist, it could be patient compliance. It could be access to medications, whether it be because of cost. It could be transportation issues. There's a whole host of barriers that could get in the way of your patient achieving their goals. And this is where you identify those and try to think through with the patient, how do we overcome these goals? And then 4th, the self-management plan might be a written kind of goal sheet that you give to the patient that involves weighing themselves once a day or taking their blood glucose levels, certain intervals, or a whole host of other things. But these are ways that you think through how to help patients help themselves. Give them exercise goals, give them sleeping goals, give them medication compliance goals, give them any types of goals that you think would assist them with their care when they're not with you. And then, of course, this all has to be provided in writing to the patient. Now, why this can be difficult is that in many cases, the physician practices that we've worked with in the past, they have given these goals to the patient. They have helped them with barriers. They've given them self-management plans, but they haven't given it to them in writing, and they haven't recorded it in the medical record. Because at some point, in order to prove that you do this to NCQA, what you're going to have to do is a chart audit or an electronic audit of your charts that will show how often you're actually doing this for your high-risk patients. And so if you don't chart in a way that records the fact that you've done this in your medical records, then you're not going to be able to prove to NCQA. And if you look at that paragraph right under element B where it says at least 75%, so you don't have to be perfect. You can 3/4 of the time or more, as long as you're doing this for your high-risk patients. And remember, this is not for all your patients. This is just for those high-risk patients, that 5% or so of your patient population that you've selected. And so you're going to go back eventually and measure yourself and see, did we do this for all, or for at least 75% of our high-risk patients? And there's 2 ways that you can prove that we're going to talk about in just a second. But I did want to show you this slide. So for your high-risk patients, you do the care plan, but you also can get credit for doing medication management. And just to look back at this last slide, the care plan is the must-pass. You've got to do this. You at least have to do 3 of these 5 things for at least 75% of your high-risk patients. C is optional, but it certainly will give you 4 more points. And this is just medication management. This is about med reconciliation, which will be numbers 1 and 2 will be meaningful use. And then giving information about prescriptions at number 3, number 4, making sure the patients understand their medication, how to take it, what side effects are involved, etc. Number 5 is assessing the response patients are having to the medications that they're taking along with their adherence issues. And then number 6, documenting over-the-counter medication and other herbal therapies and supplements that they're taking. This is a lower threshold. If you see most of it's 50%, as long as you're doing this 50%, more than 50% of the time with your high-risk patients, you'll get credit for these categories. But what we need to talk about now is, how are we going to prove this down the road? And NCQA gives 2 methods. One method I'm not going to show you on slides. I'm just going to talk about. The other method is the record review workbook. First about the method that I'm not going to show you on slides, but it's one that's optional. But I will say most practices, unless you're in a sophisticated health system that has a lot of IT people that can help you design this, it's very difficult to do this way. But NCQA does allow you to track these patients in your EMR and produce a report. And that report would have to have every one of your high-risk patients that visited you within a 3-month period. And after that 3-month period, you would look and see how many patients we had that were in the high-risk group, and then how many patients did we do each factor for. So for example, how many patients did we incorporate their goals? How many patients did we do treatment goals? How many patients did we give a self-management plan to? How many patients did we give it to them in writing? If your EMR could produce a report like that, you could use your EMR system. I will say 65% or more of my practices, 70% even, have not been able to do this. I've worked with a few health systems that have been able to create EMR, the EMR's ability to do this, but I would say in most cases you're not going to be able to do this through your EMR. So if you can't do it through your EMR, you've got to use the record review workbook. And I'll also say this, a lot of practices that even could do the EMR method use the record review workbook because NCQA has already approved the record review workbook. They're familiar with it, they're used to it. And this is what the record review workbook looks like. It's an Excel file, and on the columns it has each of those factors we've just discussed. It's kind of small, but if you look closely you can see the patient goals under number 1, the treatment goals under number 2. If you look at the blue category, medication management, it matches up with standard 4C. And so what NCQA wants you to do is, instead of all your patients, they want you to pick a patient sample size of 30 patients. So you'll have 30 patients that you'll do a chart audit for. And all you do is you pick those 30, and there's a certain method for picking the 30 that I'm not going to go into today. But once you've selected your 30 patients, basically at random, you then go into each of those patients' charts, and you see, did we give that patient a care plan? And did it have their goals, our goals, self-management goals, and barriers? And as long as that's in the record, then you can say, yes, we did it for that patient. If it's not, you say no. And actually, let me show you this next slide. Each block or each cell in your Excel file there has a drop-down menu. And so what you do is, as you're going through the patient's chart, you pull up the block or the cell and you click the correct button. So if you did do the certain care management item, you can click yes. If you didn't, you click no. And you look through 30 patients' charts to determine whether you've done this or not. And as long as you've got 75% or more from 4B, and then usually 50%, more than 50% in 4C, then you'll pass those specific factors. So there's a number of different choices for answers. If you see this first answer is a yes, that means there was evidence in the patient's chart, patient number 1. Remember, you got to do this for 30 patients. I'm just showing you patient number 1. But there's evidence in the patient chart that we did incorporate their preferences into their care plan. And remember again, this is not every patient. This is just your high-risk patients that you've selected. And then, just as an example, you look through the chart and you say, you know what, I don't see any treatment goals in the chart for this patient. And you can actually go back up to 15 months to find this. And so you click no. Now, there may be some things that you just don't do. So in this case, addressing barriers, you just decided I can't do that, I can't incorporate that in my EMR or whatever reason. So NCQA gives you a not used option, so you don't have to click yes or no on every box. That basically just means no. And then if you see this fourth way you can answer, it says see report. And what that would mean is you're using a meaningful use report or maybe an EMR report, and you're not using the record review workbook. And for numbers 1 and 2 in 4C, you can actually use your meaningful use report. And I would encourage you to do that because it's a lot easier than doing the chart audit. And so in the end, you're going to have 30 patients you're going to look at. These are 30 patients in your high-risk population, and you're going to look to see if you've done each of the factors that NCQA has listed in their care planning and in their medication management. And then I just want to show you what a record review workbook looks like. It's not going to be exactly like the 2014 record review workbook because this is from 2011. And the purpose of this is not to show you in a lot of detail, but if you can look, there's a lot of red no's scattered throughout here. NCQA does not expect perfection. And in fact, if you fill out a perfect record review workbook, they're going to think that you cheated. And so it's okay if you don't get perfect on every one, and that's why they've built 75% into the standard instead of 100%. And that's why it's 50% and not 85%. So they've given you some leeway to make some mistakes and to omit certain things from the charts. But the bottom line is, if it's in your chart, then you can say yes. If it's not in your chart, even if you've done it, NCQA does not consider you as having done it. The other thing is, if you use this record review workbook method, NCQA wants you to give an example of each of these things. So you'd want to give an example of a care plan that has goals, self-management plan, etc. You'd want to give an example of your medication management. They do want to see examples of this. You do not have to give examples if you use the EMR proving method. And then this is from last month's webinar, and I said I would mention it again this month. 3C gives you the option of using the record review workbook to prove that you've done these comprehensive health assessment factors. And that's the method I'm typically recommending for practices, because most of y'all don't have structured data fields that you can pull reports from, like with med history or with behaviors affecting health, depression screening, etc. And so the record review workbook just looks like what we've just seen, and you do the same thing. You look through the patient's chart, and if you've done the immunizations, if you recorded those, then you say yes. If you've recorded whether they're blind, deaf, or have other communication needs, you would say yes. If you've recorded their med history, you would say yes. I mean, it's just like it is the record review workbook, but you can use the same patient sample that you're using for 4B and C for standard 3C. And so the record review workbook and this care planning is certainly one of the more arduous and difficult parts of the patient-centered medical home, but we can really help you streamline this. We've done this a lot. We've done a lot of record review workbooks. We've also helped a lot of practices think through how best to organize their clinical workflows to incorporate this. We've designed a lot of templates that practices can use to capture this information. And so we really do make it a lot easier than it would be otherwise, and encourage you to use us and the experience we have to assist you. Now we're at element 4D, and this is e-prescribing. Most of this is, or not most, but some of this is meaningful use. So numbers 1 and 2 here about prescriptions that are electronically sent to pharmacies and compared to drug formularies, and then electronic medication orders in the record. Those are meaningful use that we'll use meaningful use reports for most likely. And then factors 3 and 4 are screenshots that we'll take, and I'll show you some examples of that in just a second. If you recall, number 1 about e-prescribing, this just shows that the system will warn you if you've got an off-formulary medication that you've prescribed for the patient. But again, we'll be able to do a meaningful use report for this one. But factor 3, like an example of drug-drug interaction, let's say you prescribe your patient one drug and your EMR will pop up a warning saying if you've recorded in the EMR that they take other drugs that would have interactions, it would pop up a warning box warning you about what the interaction might be. Allergy interaction, where if you prescribe someone a medication that they've indicated an allergy to, then your EMR is sending automatic pop-ups. In most cases, I mean, your EMR either does this or it doesn't, and in most EMRs it does, so we'll just take screenshots. And then just an example of alerting you that there is a generic alternative. Again, most EMRs do this, and so it's really a question of whether yours does or doesn't. And if it does, you'll get the points. If it doesn't, then you won't. It's only worth 3 points total, so it's not that big of a deal if you can't get all these points. And then standard 4E, this is basically showing NCQA a number of examples of how you provide education to your patients. Number 1 here is using your electronic health record system to produce specific education related to patients' conditions and treatment, and that's meaningful use. So we'll use a meaningful use report for number 1. And then numbers 2 through 5, NCQA just wants you to provide examples. Show them, I think it's at least 3, it is at least 3 examples of educational materials and resources you use with your patients. So if you're giving your patient a Bright Futures handout for developmental milestones when they're in your office for a 4-year-old well visit, that's an example. or you give them a diabetic flow sheet to think through how to take care of their diabetes at home, or you give them an asthma worksheet, or you give them any variety of things that you're giving to your patients. We're just going to show 3 examples of each of these things. The self-management tool is, again, something that a patient could use to record their care at home. It's pretty typical to give these to a heart failure patient, diabetic, hypertensive patient, asthma patients, ADHD patients. Obesity is another one where there's a lot of tools you can use. And so again, we're just going to show NCQA several examples of tools that you're using. They also want you to offer health education programs. So if you're offering classes in your office, it could be about breastfeeding, it could be about how to handle diabetes. I mean, the sky's the limit. So really, it's more, we'll do an inventory of what your practice offers, and as long as you've got enough to satisfy NCQA requirements, you'll be fine. And then numbers 6 and 7 are more about the community resources that you make available, and that's just having at least 5, a list of at least 5 community resources that you use. This is not clinical. This is more like United Way or a food bank or transportation services. Dental care can also be included in there. I'll show you an example of one of those. First, here's an example of a self-management tool for a diabetic where the patient just has the ability to record at home and at the office what their results are over time. Here's an example of community resources from one practice. And again, it's not really clinical as much as it's kind of meeting the social determinants of health or other issues related to their care that aren't necessarily clinical in nature. Here's one from a practice I work with. Again, most practices have this. This is not going to be an issue for them. Well, I know that was a brief summary of Standard 4, but Standard 4 is a lot of one-on-one coaching because each practice is different. Each practice will have a different high-risk population. Each practice will address the way that they record the results for the care management that they're providing. There's going to be different ways that y'all are going to want to do that. And so what we've been trained to do and will do is help you think through what are the best ways to handle this. So we appreciate you being a part of this webinar. We're going to be talking about Standard 5 next month in September. And until then, if you've got questions or have any comments or any other type of feedback, we always welcome that. And you can reach us at scotth@scmedical.org, scotth@scmedical.org. Thanks for listening, and see you next month.